morning, all of you. I'm Dr. M. Ashok Kumar, Professor and Head of the Department of General Medicine, Government Medical College, Sangareddy. I welcome you all today to today's seminar on hypertension. Hypertension is one of the leading causes of coronary artery disease, cardiovascular disease, chronic kidney disease, and which leads to morbidity and mortality. Hypertension, otherwise called as high BP, affects mostly the elder age group. Initially, it was seen in the elder age group, but now there is no age group. Any person above the age of 18 is mostly affected with high BP or hypertension. When do we call hypertension? See, when the BP is more than 140/90 systolic, 140 systolic, 90 diastolic, we call it as hypertension. There are two types of hypertension. One is called essential hypertension or primary hypertension, and second one is secondary hypertension. In 80 to 95% of the cases, we see primary hypertension where the cause is not known. It is called idiopathic. And in rest of the cases, we call it a secondary hypertension where there is a cause secondary to some other medical disease. Coming to the secondary hypertension, in 5% of the cases where we see it, it could be secondary to chronic kidney disease, coarctation of aorta, renal parenchymal disease, pheochromocytoma, coarctation of aorta. There are so many other causes of secondary hypertension. Now coming to the symptomatology. Most of the times, the hypertension is a symptomless disease, what we call it as a symptomless disease, because the patient never complains of any symptoms. It is a silent killer. Next, palpitations. So these could be the symptoms of hypertension. When the patient comes with this hypertension, we have to think the patient is having high blood pressure and we have to start the treatment. Coming to the investigation, what are the routine investigations we have to do when a patient is having hypertension? Apart from the routine investigations like CBP, random blood sugar, renal function tests like blood urea, serum creatinine, EG, estimated glomerular filtration rate, serum lipid profile, liver function test. We have to screen for other secondary causes to rule out the secondary hypertension, like metanephrin, urine for metanephrin, and renal artery stenosis. To rule out renal artery stenosis, we have to go for color Doppler of renal arteries, ultrasound abdomen to see the size of the kidneys, and go for an ECG. And you have to go do a routine 2D echo scanning also. See, once the investigations are over, now we have to advise the patient. So first of all, lifestyle modifications is very, very important rather than going for medication direct. So what do you mean by lifestyle modifications? First is DASH diet, DASH, DASH diet, what we recommend usually to the patients. Dietary approach to stop hypertension. So as we all know, what are the causes of hypertension? One is high salt intake, sedentary lifestyle, then low potassium intake, excessive intake of alcohol, next is tobacco, smoking. So these are all the risk factors for hypertension. So we have to address these in the DASH diet. First and foremost, very important in lifestyle modifications is ask the patient to restrict the salt intake less than 5 grams per day. If the patient is having 1 teaspoon, ask the patient to reduce it to half a teaspoon per day. So he has to cut down the sodium intake by 50%. More importantly, ask the patient not to take extra added salt. Then you should avoid pickles and all those things. So salt, overall, the patient has to reduce the sodium intake. Second, fat restricted diet. Second is, what does it mean? Ask the patient to reduce his non-vegetarian red meat intake and ask him to take more of fish, white meat or lean meat like fish, chicken, and egg whites, not the yellow yolk. So first thing in the lifestyle modification is salt, fat restricted diet. Second, physical activity. We have to recommend the patient to at least do 45 minutes exercise per day, apart from his routine activities. So at least the patient has to do 150 minutes per week. If at all is not possible for daily 45 minutes, we have to recommend the patient to do at least 150 minutes per week. So physical activity is a very, very important in lifestyle modification. Third thing, ask the patient to consume lot of greens, vegetables and salads, fruits, vegetables and salad. Increased intake of fruits, vegetables and salads. That way the patient will consume a lot of potassium and thereby that will reduce his high blood pressure. Fourth thing is alcohol moderation. Ask the patient to restrict his alcohol intake and he has to stop smoking. These are the 5 things in lifestyle modification which we advise to the patient. Then coming to the pharmacotherapy or drug therapy to treat hypertension. We all know there are 5 classes of drugs in our armamentarium to treat the hypertension. That mnemonic we all know, A, B, C, D. A stands for ACE inhibitors and ARBs. B stands for beta blockers. C for calcium channel blockers. D for diuretics. And E is other class of drugs like alpha blockers and centrally acting drugs. So A's or ARBs, previously the beta blockers were the first choice of antihypertensive drugs. But nowadays, we are not using it as a first choice. Now the first choice is AC inhibitors or ARBs, angiotensin receptor blocking drugs. So first we have to start the patient with ACE or ARBs depending upon the situation and a single drug. Then we have to monitor if if the BP doesn't come below 130/80, we have to add a second drug, add-on drug. Like we can add calcium channel blockers or a beta blockers or a diuretics to the ACE or ARBs. So we have to put the patient on single drug, dual drug, or triple drug, depending upon the condition of the patient. Then the response to the drugs, antihypertensive drugs. There's some indications and contraindications before starting the ACE and ARBs. So indications is essential hypertension, secondary hypertension, we can start the patient. But we have to be very careful. There are some side effects like on ACE inhibitors causes chronic cough. In some patients, it may cause angioneurotic edema, allergy, and all. So we have to caution the patient while starting antihypertensive drugs. If at all, if we have any of the side effects, we ask him to report to the doctor immediately. And one important contraindication for ACE and ARBs is pregnancy. It is an absolute contraindication. We should not use this ACE and ARBs in pregnant women, and at the same time, not use this in bilateral renal artery stenosis. If the patient is having bilateral renal artery stenosis, we are not supposed to use ACE and ARBs. We have the other choice like calcium channel, beta blockers, and diuretics. Now coming to the beta blockers. There are so many beta blockers as they're starting with atenolol, metoprolol. So many wide choices there. Cardioselective beta blockers. Usually metoprolol we are using in hypertension, and that too the indication is in post-MI cases. Most of the patients we use beta blockers. And one of the contraindication of beta blockers is we have to be very careful when the patient is having bronchial asthma. We should avoid the patient beta blockers in bronchial asthma patient. And calcium channel blockers, we have dihydropyridine groups and non-dihydropyridine groups. So many groups. And now coming to the most commonly used drugs in calcium channel blockers, we have amlodipine, cilnidipine, benadipine. So depending upon that, we can use this. And when coming to the calcium channel blockers, there we have to keep it in mind before starting it. There are 2 side effects usually we see in our routine practice. One is bilateral pedal edema, and second is a headache. If the patient complains with these 2 symptoms, we have to see and we have to change the drug. And coming to diuretics, we have so many other choices. So suppose the patient is having a congestive cardiac failure and pedal edema and all those things, we can put the patient on diuretics, like potassium sparing diuretics. We have so many classic thiazide group diuretics we have. And coming to the last category of drugs, we have centrally acting drugs and alpha blockers. So when the patient is having resistant hypertension, one word of caution, in spite of all these drugs, if the patient doesn't respond to our treatment, we call it as resistant hypertension. If the patient is on 3 drugs which includes a diuretic, and all the three drugs in optimum doses. In spite of all these things and lifestyle modifications, if the patient doesn't respond, we call it as resistant hypertension. Then we have to start the patient on alpha blockers or centrally acting drugs apart from all these drugs. And last but not least, there's a surgical treatment, renal denervation, that is treatment for resistant hypertension. So most important thing is the lifestyle modification. We have to stress more on lifestyle modifications to prevent hypertension. And there's a latest government regulation that every citizen above the age of 18 years should be periodically screened for hypertension.